exam in here today, a week from today, right? Oh, a week from Wednesday. That's right. That's right. We're going to do a review on Monday. Okay. We can move it ahead if you want. Okay. Just ask. All right, so we're going to talk about congenital heart diseases, and as we'll find, we can describe them as either being cyanotic, meaning the baby will be blue, or they'll be acyanotic. In some cases, unfortunately, they can be either. We'll talk about the defect that is present for each of these, and we'll talk about, for many of them, if there's any surgical repair, what has to be done to be able to correct the defect and allow for a relatively normal childhood. These are the defects we'll talk about that you'll have to know. I think I added one on from your list called tricuspid atresia, but when we get there, we'll add that one on. It's not till next time anyway, so. Okay? So these are some really good websites because parents of kids with cardiac abnormalities, you need to dumb it down considerably to be able to talk to them. Some really nice websites. This one, I believe, this first one, basically describes it as a house with rooms and whether there's a wall or a door present. It's kind of an easy analogy to follow. So all of these, believe me, if something doesn't make sense, just Google it. You'll find about 8 million websites explaining it. So basically, under normal conditions, you end up having, once you convert to post-uterine life, you have a closure of the ductus arteriosus, a closure of the foramen ovale, and you end up then having blood flow occurring. This is kind of just showing it. If the foramen ovale did not close, you would end up having actually a left to right shunt because the pressure in the left atrium is higher than that in the right atrium. So it's going to go from a left to right. Everything is determined by, let me rephrase that. Any blood flow is determined by pressure differential. So long as there's a pressure differential between the left atrium and the right atrium, and that foramen ovale has not formally closed, it'll always be a left to right shunt. Okay. So just bear in mind what the normal is. It'll help you to go with the abnormal. So let's talk about the first one, the ductus arteriosus. We know that it's part of the fetal circulation. We know that it connects the pulmonary artery to the aorta. The exact location of that can vary. And it basically is designed to prevent blood flow from going through to the lungs. What blood does not skip by the lungs by going through the foramen ovale into the left atrium and through the left ventricle and out through the aorta, that portion that does go through into the right ventricle predominantly moves then from the pulmonary artery into the aorta and again bypasses the lungs. It's maintained patency by the presence of these prostaglandins, and what ends up happening is as that first breath happens, as the PaO2 rises, the level of prostaglandins that are circulating goes down and the closure begins. Maybe if I talk slower, I won't have as many problems. There are those I know amongst you who would say, can you do that all the time? So there it is. Roughly 1 in 2,000 live births, higher in premature babies than it is in term babies. And for whatever reason, it's more common in females than males. It's the 5th or 6th, depending upon who you count, common congenital heart defect, and often it has to be there with other, it's present with other defects, and in some cases, if you don't have it, you don't survive birth. So, the degree of morbidity and mortality, do we know the difference between those two terms? Let's start with the easy one. Mortality? Death. Okay, good. Morbidity? Problems, illnesses. Okay, so we can say we have comorbidities in the sense that I have COPD and I have congestive heart failure. They're seen together often, so we call them comorbidities. But in this case, morbidity meaning that I have a problem associated with that defect being present. And it's determined by how big it is. And you can see there it is, the location of it. And the way the diagram is showing with this patent ductus arteriosus, it's looking like the blood is moving from the aorta to the pulmonary artery, and that would occur if the pressure in the aorta is higher than the pressure in the pulmonary artery. It's going to go in whichever direction has the higher blood pressure. That's where it's going to be pushed through.
So wherever the gradient tells it to go.
That's correct. So in the case of a situation where the systemic blood pressure is higher than your pulmonary artery pressure, here the pulmonary artery pressures, give me a little pen here, hold on here. We got to do this right. Here my pulmonary artery pressure is 30/10. My systemic blood pressure is 110/60. The arterial blood oxygen level is 95. My venous blood level is 75, but since some of this oxygenated blood is now mixing in, the pulmonary artery pressure is now high, or the pulmonary artery saturation is now higher. Okay? But that's not the normal process that goes on when we have a patent ductus arteriosus. When I have a drop in the pulmonary artery pressure, secondary through that pulmonary vasculature closing down, or pulmonary vasculature dilating, that if the PDA remains open, as we saw in this last slide, you're going to have that aortic blood mixing in, and in that case, it's going to be a left to right shunt, and the baby's going to appear acyanotic. Okay? That's not a good thing necessarily, because if there's a large amount of blood flow that is going from left to right through that ductus arteriosus, I'm having increased blood flow, which potentially could lead to pulmonary edema. Does that make sense? I'm putting more blood in there than it's supposed to have. So I can end up having a reduction in PO2 secondary to that pulmonary edema. Also, concomitantly, I'm also not putting blood to the peripheral organs because I'm having reduced aortic blood flow, which could potentially lead to the development of necrotizing enterocolitis. If you remember, that has to do with poor perfusion to the splanchnic vessels in the intestinal walls. Okay. On the other hand, should the PA pressure rise above the systemic pressure, like you would have, say, in pulmonary persistent hypertension of the newborn, then I would have a right to left shunt, venous blood moving in with arterial blood, leading to cyanosis. So this is one of those weird defects that can be cyanotic or acyanotic depending upon what the relationship is between systemic and pulmonary artery pressures. Yes? Probably the latter, the right to left shunt, because we end up seeing that more so with the other diseases that are present because a child's hypoxemic secondary to, say, RDS or diaphragmatic hernia, that's going to cause them then to have the pulmonary hypertension remaining, and you'll end up having that right to left shunt present. Usually the left to right, that's going to close off really quick. And under ordinary conditions, you don't have this process where you have this increased blood flow for very long. Okay, but potentially it can happen.
When you have reduced blood flow to postductal organs, anything postductal would have reduced blood flow?
Mm-hmm. Kidney.
Wouldn't that leave you cyanotic though?
No, not necessarily. Might have you might have a lower blood pressure, but it's not necessarily going to be cyanosis. Maybe peripheral cyanosis, but even then, not so much. No? Not to the extent that you would see like post-birth, where you have the acrocyanosis with really profound reduction in perfusion. Because
I figured if there's enough to necrotize organs.
Well, potentially it can happen, yeah, but it typically is not. Like I said, this first scenario is probably less common than is less common than the secondary one. Okay. So what you'll end up hearing is a grade 1 or grade 3 systolic murmur. it's described as being like a washing machine. Let me see if I can get this to work. That's normal. I got them both going at once. But you can hear there's all kind of blood flow moving back and forth. And by the way, how we diagnose it is not just simply by listening for a grade 3 systolic murmur. We're also going to be doing it through echocardiography. Hint, pretty much every one of these defects we can diagnose with echocardiography. So when in doubt, select echocardiography. So what we really need to do is if we're seeing the congestive heart failure, we're going to treat that by giving them what you would for congestive heart failure in the adult. We're going to give them fluid restriction. We're going to give them diuretics. We're going to give them inotropes to make the horse work harder. I think Jeannie, did Jeannie talk about the cart and the horse analogy? Same idea here. The whip, you got it. And then again, we can also stimulate closure of that PDA through a prostaglandin inhibitor, a drug by the name of indomethacin. Indomethacin. Kind of sounds like it's got a, like it's something dangerous. Is it? Okay, I apologize. What else is on there?
That makes me feel better.
You don't have, you don't have DIG? Yeah. Okay. Yeah, throw DIG in there.
Basically, you're treating heart failure.
And in severe cases, they could actually go in and ligate it, although typically the closure will end up happening kind of on its own. So long as the PO2 is maintained high. Yes, Dana?
So, only for heart failure, we only restrict the fluids and diuretics, and then for the closure of the PDA, we only do the inhibitors and...
No, not only. We keep PaO2 high,
Okay.
higher. We don't let the patient become hypoxemic.
Okay.
Because anytime you have a hypoxemic patient, remember hypoxemia is a very potent pulmonary vasoconstrictor. Okay, which is going to drive PA pressure up, which is going to further worsen the problem.
Okay.
So we want to vasodilate as much as possible, get the PaO2 up. Okay, so that's number one. Number two, ASD, atrial septal defects. Again, a little less common, but still there. Again, females more than males, don't have any idea why. And I don't really care that you know this next point, but I think it's kind of cool. There's two different spots that it can happen where you can actually have, and this is the first one is the most common one, where it's at the foramen ovale. But there's also, you can end up having it where the SVC and the IVC attach to the right atrium. You can end up having some connections there also. Kind of an interesting fact there. 60 years ago, they wouldn't have reached the first grade. Now, absolutely no issue with some surgical repair. And again, it depends on the size of the defect which is present. So here we end up seeing the normal heart where there is no connection between these two. Here we have a atrial septal defect, and depending upon which pressure is higher, this is depicting a left atrial pressure that is higher than the right atrial pressure. So I end up having blood flow moving from left to right. But again, depending upon which side is higher, it can go the opposite way also. And this is just showing those sinus venosus, sinus secundum, and sinus cavale, which are the different spots where the defect can occur. The middle one is the most common one we end up encountering. I don't really care that you know the fancy names for them. Okay. So there I have my left atrial pressure higher than my right. We get a little right to left. Just showing it again. Here I have my left ventricular, left atrial, pulmonary vein, high in oxygen. Inferior, superior vena cava, low in oxygen. The pressure here is higher than the pressure here. Blood moves left to right, and I end up having a pulmonary artery pressure again. And the same kind of thing that would happen with the ductus arteriosus, where the aortic pressure exceeds the pulmonary artery pressure. Blood flow to the lungs are going to be increased, and the same kind of picture happens. In a lot of cases, because the amount of blood that moves through that opening is not as significant, you can actually not notice it until later in life where they pick up a murmur on it. If it is a significant defect, then you'll end up hearing those things later in life. And you hear the murmur? A little bit of a lag there. Okay, you can stop now. How do we treat it? We close it if it's big enough. And they're also, they can do this either surgically or they can do this through a cath. And you can actually see they go in, and I don't know if you can make it out there, but these are sutures. They're basically taking a graft and sewing it together, closing up the hole, putting a finger in the dike, if you will.
So when someone's born, when somebody says they're born with a hole in their heart, is this what they?
Probably an ASD, but as we'll see the next one, VSD is possible. Dana.
Do we, do we help out in any?
Nah.
Okay.
That's all done in the OR.
Alright.
Yeah.
It's a patch.
It's a patch. Yeah. It's like you got a hole in your tire, you just patch it back up again. Your bike tire. Bike tube, I guess it would be, wouldn't it? Yeah. VSD. This is another hole in the heart, if you will. Only in this case, the hole is on between the two ventricles. And again, back in 1950, you didn't even survive. Today, excellent process as far as closure. And there actually have been situations where they were born with both an ASD and a VSD. And you can see that there were some successful closures with that. And this is again showing the two. And because the pressure on the left is higher than the pressure on the right, you end up having blood flow moving from right to left, or from left to right, excuse me. So left ventricular pressure higher than right ventricular pressure, blood is going to move in that direction again, and then allowing for a higher pulmonary artery saturation. And depending upon the size of that, again, is going to affect how much blood flow goes over. So ASD, VSD, both of them are probably going to be acyanotic issues. So again, depends on what that pulmonary vascular resistance is. If I have a child who's hypoxemic with a high PVR, you're going to end up seeing a right to left at that point in time. And I'm not going to worry about the murmurs. They're the same kind of a thing. You diagnose it with that, and basically an echo is what you're going to find it with. You can have just a VSD by itself, but as we'll see in a few minutes, there's a lot of instances where they're located along with some other cardiac defect. And in a lot of cases, if the VSD wasn't there, they'd be dead. So we just basically monitor it, and again, if it gets very, very large, especially if you end up having a situation where there's persistent pulmonary hypertension, a child will end up having a need for some surgical closure at some point along the line. Okay, first of the weird ones, like those weren't weird enough, just having simply a little hole in your heart. Tetralogy of Fallot. It is the most common cyanotic defect, and as you get older, the mortality gets higher if it's uncorrected, and this is why in like 1950, as we said, it was fatal. Today we're looking at 5% mortality, and in most cases they end up having a normal childhood, nothing going on. Tetralogy implies that there's 4 defects. These might be a good thing to know. The 4 defects are that you have a pulmonary stenosis, you have a usually quite large ventricular septal defect, you don't have 2 separate vessels, pulmonary artery, aorta. Nah, you just got this one big vessel kind of hanging over both ventricles. We're going to call an overriding aorta. And because you have that pulmonary artery stenosis, you end up having right ventricular hypertrophy because it's got to pump against a valve that's very narrow. Okay? So pulmonary artery stenosis, VSD, overriding aorta, right ventricular hypertrophy. So here's what my normal heart would look like. And you can see, first of all, I have a pulmonary artery stenosis where this valve, instead of being a nice pliant valve, becomes very narrowed and doesn't move much. Second thing I have is a huge VSD. Third thing I have is I have an aorta that is kind of overriding both. And the last thing I have is right ventricular hypertrophy, where the right ventricle actually is thicker than the left.
So when you
Yeah.
have that hypertrophy, does it actually cost you volume in that right ventricle? That's kind of what we're shown there.
It's not so much that the filling volume is less, because it's getting some of the filling volume from the left side of the heart, from the VSD. But the problem you end up having is you end up having venous blood and arterial blood mixing together. I think the next slide shows that. Yeah, go ahead before I go on, Liz. It just is one vessel which is kind of over both, and they both kind of dump into it. So in other words, the right ventricular output and the left ventricular output kind of go through a common vessel.
You have to have all four of them dead at
Yes. Actually, if you didn't have the VSD, you wouldn't survive. So that has to be there. And it's really the pulmonary stenosis that kind of causes everything to start with. That's kind of the defect that is. I don't want to say it's the primary one, but it's the one that's the truly limiting. The larger the pulmonary stenosis, the worse everything else is. Yeah, Steve.
pulmonary stenosis, you need
The valve.
the valve
The pulmonary valve itself, correct. Thank you. So here we end up having that pulmonary stenosis, and because of that, blood flow is diverted from right to left. That means that I end up having venous blood, high right ventricular pressure, blood flow moving across, this poorly saturated blood now mixing with my well saturated, and I end up having a reduction in arterial oxygenation. Okay. They end up having what are called TET spells, which are basically periods of time where due to stressors, for whatever reason, the pulmonary artery pressure becomes higher than it previously was, and the degree of hypoxemia becomes greater, and the blue discoloration, shall we say, becomes worse. Okay. It's been described as having a boot-shaped heart. I don't make these things up. When you look at the X-ray, you're going to go, "That's a boot-shaped?" Okay. Okay. Amazingly, we diagnose it with echocardiography. And the surgical correction, it can be reparative, meaning it can completely close it, or if the defect is so large that the damage is there and done, and really the pulmonary stenosis is so significant that there's not much else we can end up doing with it. It could be palliative in nature. Palliative meaning we just make things better. It's not going to correct it. What I do want you to know is that it's the Blaylock-Taussig maneuver. I'll talk more about that in a half a second. But these are microsurgeries that they're ending up doing, so it's pretty amazing when you think about it. Boot-shaped. Ooh, that's a real stretch. Okay. And this is the procedure that they end up doing. They end up taking one of the branches of the aorta, typically the subclavian, and attaching it to the pulmonary artery. So basically what you're doing is as blood flow is coming out through the aorta, it's being redirected back into the pulmonary arteries because the blood flow through that stenotic valve isn't there. instead of doing an actual connection, they can actually put in a graft between the two and attach the two. If you have ever seen this movie, if you haven't seen it, when you're on break, I encourage you going on Netflix. I'm sure it's on there. Something the Lord Made. It's a fascinating movie. It talks about, well, hell, I'll play the trailer. Let's see if this will run.
Why can't they just fix this stenosis?
It's so significant that they can't. Well, at least at that point, well, they still don't even today replace the valve. They just bypass it.
Morning. Why would a doctor want to hire a carpenter?
This is where my work is done.
What is your work?
Medical research. Let me see those hands.
You must have got it. Oh, Vivian! He's working at a hospital, right?
Yeah.
Everyone gives you so much money.
Vivian, Dr. Bleedoff wanted you to have this.
Excuse me, all workers punch in at the rear entrance.
He's with me.
I'm sorry, Dr. Blaylock, but that's the rules.
I don't think that she's breathing right now. I don't think that she's breathing.
That baby back there, how long?
6 months. Are you going to take this on, doctor?
No one's ever done anything as hard as this.
You can't operate on the heart, that's basic.
There must be a way to get more blood to the lungs.
If we focus on the pulmonary artery.
Oh, on this God's earth are you?
You got that white coat, you're just a class 3, work the same as me.
I'd like some coffee and a donut.
What about you going to medical school?
You don't have to remind me of that, Clara. We have a family now.
Let's start with experiments. Let's break their rules. You can begin the incision.
I'm not ready for that.
If I say you're ready, you're ready.
You have to see this. Vivian Thomas is operating, assisted by the chief of surgery.
Retract.
No sushi.
Can't we try things my way occasionally? I think we've found a way to repair your daughter's heart.
Your quest for glory is vain.
Postpone the operation until you have more experience. Postponing means signing that baby's death warrant. I'm operating tomorrow. Agent Vivian Thomas.
What's wrong? What's happened?
Agent Vivian Thomas. You're running an OR right now. You're talking me through this. Scrub up.
What's he doing here?
You can resume your duties.
These are his duties. We made history together. We changed the world.
You can see it's a few years old, but the film was actually set in 1944. It was actually, I think, I want to say it was Baltimore, but it was definitely a different time, shall we say? Vivian Thomas actually got an honorary medical degree, I believe, as a part of this. But it's a fascinating story, and Eileen Saxon is obviously the little baby there that they ended up saving. So heart-wrenching movie, but a good one. Blaylock Tausig. By the way, Blaylock was Alan Rickman, and Tausig was the female who brought him the patient. Mary Stuart Masterson, I think is the actor who played her. Actress. Okay. Complete transposition of the great arteries. That sounds like a real mess. Again, cyanotic defect. The aorta comes off the right ventricle. It's also known as great transposition of the great vessels, yes. Both ways. Pulmonary artery arises from the left ventricle. Good Lord doesn't always get this stuff straight. He kind of mixed them up. One comes from one and comes from the other. Now, obviously, if you didn't have some kind of an atrial or ventricular septal defect, you'd be dead, because you would have two independent circuits not connecting with each other. So you have to have an ASD. In most cases, it's a VSD, and they often have a PDA that remains open secondary to the hypoxia, which is okay, because we need it. So here we end up having the aorta coming off the right ventricle. the pulmonary artery coming off the left ventricle. Usually there's a pretty substantial ductus arteriosus that is present to sustain life, or there has to be a pretty big ventricular septal defect, or in even some cases a right atrial defect. Okay, it's got to be some connection to be able to push blood through. Obviously, this is going to be a cyanotic defect. You got blood coming from the right ventricle, going into the systemic circulation, and hopefully coming back through to the aorta, being fed with some of the blood from the pulmonary artery. Mess. Okay. So here, this kind of is a diagram. Have an ASD here in this case. You can also have a connection here through the ductus arteriosus. But my left ventricular pressure is going to be significantly less because the pulmonary artery system is not that high of a system. Right ventricular is going to be the workhorse in this case because the aortic pressure is a whole lot higher. And you'll end up having blood flow that's basically shunted then back through around. But the bottom line is that I got a lot of venous blood that's being pumped out through the aorta because it's coming from the systemic circulation with a low saturation. Reversed. Got to fix the plumbing there. Now, why they call it an egg on a string, as you'll see when I show you a picture, I got no idea on that one. But okay, that's what's defined as. We diagnose it again by echocardiography. They do all kind of things to basically recreate of the foramen ovale, make it larger again. You don't need to know the Rashkin's procedure for that one. I'm not real worried about that. But we're going to try everything we can to keep those secondary shunting things open. If it means making the atrial septal defect bigger, making that foramen ovale stay open, be it. Giving them prostaglandins to actually keep the PDA open. Sounds kind of counterintuitive, but we may need to do it. And there's actually a surgical connection for right now. I'm not concerned that you notice the Jantine operation, but that's what they end up doing. So here they're creating an intra-atrial baffling process. It's called a mustard procedure. You'll hear that term used when you rotate through a pediatric surgical center. And they basically then try to separate the two in the process. Now, how that's an egg on a string, I got no idea. I guess it kind of looks like an egg. Next one, coarctation. It's basically a constriction of the aorta where you end up having a reduction in blood flow through the aortic arch. Obviously, that's going to cause more work on the left side of the heart, leading to heart failure. Where the location of narrowing is determines what kind of signs and symptoms you'll end up seeing. They often will, again, have some sort of a PDA or a VSD, and often because of the extra work on the left side of the heart pumping out through the aortic valve can be malfunctioning also. Here's an example of the coarctation, a narrowing that occurs. This happens to be postductal. The worst scenarios are when they're preductal. Okay. It's less common, but it's more serious. And then you really do have to have an intact VSD or PDA or transposition present, because that ductus or that preductal compression is going to make blood flow very, very difficult through there. What we end up seeing more often is the postductal, again, as we saw in that prior diagram. Which means that you have to have some other collateral circulation present beyond the coarctation to reduce the amount of blood flow problems that you end up seeing. The uniqueness of this, especially if, let me just go back my slide here. Whoop. What you'll end up seeing is that this is going where? Left arm. This ends up going to the right arm. So what you end up seeing is that if you take a blood pressure in the arms, they're higher than the blood pressure in the legs. That's what you end up seeing. The upper extremities, higher blood pressure than the lower extremities, because it's getting more blood flow. coarctation of the aorta. Again, we diagnose it. You can actually diagnose it through a chest x-ray, and I'll show you an example of that. But more often it's, again, through echocardiography, and they can actually do cardiac caths also. Support them with, support their blood pressure, however is necessary. We want to give prostaglandins, again, to keep that PDA open. And basically what they do is they go in, cut out the coarctation, and reattach the aorta to itself.
My girlfriend's daughter just had this done like 3 or 4 months ago.
All is well?
Yeah.
All is well. Without surgery, we're talking about, you know,
But they knew she had that before she was even born.
Yeah.
Like they found it in the ultrasound.
Here's the chest x-ray. And there's all kind of other stuff that they have on here as far as picking up notching of the ribs and all this other stuff. Here's my aortic arch. That's what it should look like. You can see the coarctation, narrowing of it. I'm not even good at chest x-rays, so I can pick that up. Shoot. Okay. The next one. Is my head getting hurt yet? You're okay. Then I'll keep going. Anomalous venous return, meaning that we have pulmonary venous blood being dumped into the right atrium instead of the left. Huh? Coming back from the lungs, doesn't go to the left atrium. It joins up with the superior vena cava and actually dumps right back into the right atrium. If you didn't have an ASD, obviously you wouldn't be able to live. You can have partial connection where maybe only one of the pulmonary veins is attached. Usually ends up being a cyanotic defect. Amazingly, we diagnose it with echocardiography. And what we basically do is surgically go back in and put them back where they belong. So here's my pulmonary vein. And this is an example here where all 4 pulmonary veins dump back into the aorta. Here's my pulmonary vein. Boom, boom. All 4 of them dump back in. And I have to have, again, that atrial septal defect. Otherwise, there would be no blood flow getting to the systemic circulation. However, that's venous blood dumping in. So that's why we end up having a cyanotic defect.
Correct, the only pathway to the left ventricle is for the defect then?
Yep. Truncus arteriosus. It just sounds like it should be a cartoon character, you know. One large vessel arises from over the right and left with a VSD. Again, a cyanotic defect. And basically what we attempt to do is separate the pulmonary artery from the truncus, close off the VSD, and create a connection between the right ventricle and the pulmonary artery. So here I have, again, kind of like an overriding aorta where it's feeding both of them together. The pulmonary artery and the aorta are not 2 distinct vessels. They've just kind of merged together. As blood returns from the left side of the lung, there has to be a VSD there. Otherwise, you wouldn't be able to get any connection between the two in this centralized truncus in the process. So what they would end up doing is surgically repairing this, closing this off, and making sure we had an ability to get blood flow to the lungs in the process. And there's basically what they do. They just graft in a new pulmonary artery to be able to attach it to the right ventricle and close off the VSD. And I think I'll stop there.